Welcome to our conference session titled Living with Aplastic Anemia. Thank you for joining us today. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of all of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit your questions at any time using the Q&A icon found in the engagement panel on your right. To submit a question or a comment, type your question in the Q&A box, and just when you're done typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit all your question at the same time. Second, please do not include private health information in your question. Our expert speaker cannot answer any questions specific to your personal health care. Our specialist today is Swapna Thota. Dr. Thota is an Associate Program Director at UTHSC, Memphis, in the medical hematology and an associate professor of medicine. Her clinical practice focuses on bone marrow failure states, including acute leukemias, myelodysplastic syndrome, myeloproliferative neoplasms, aplastic anemia, and related disorders. As a clinical researcher, she is interested in diversity, inclusion, access to care for all, as well as translational research and myeloid malignancies. It's my extreme pleasure to welcome Dr. Thota.
Thank you all so much. I really would like to begin for thanking you all for your time, for being here in beautiful city of Memphis on the campus of University of Tennessee to promote our purpose of increasing community awareness for patients suffering through rare blood disorders. Like I have mentioned, it's an extremely isolating process to be diagnosed with any illness during the productive phase of your life. At the same time, there is no other person you've met during your lifetime with the same diagnosis. So it becomes an extremely isolating process. The idea of today's presentation is to bring that community together, people who do the research, people who do the treatments, and the patients and their families together. So I appreciate all your time. I focus in my clinic on many blood disorders, especially on blood cancers and bone marrow failure conditions. One of the most gratifying experiences my team has as we take patients through this process is they present to us really tired and fatigued with extremely low blood counts, not knowing what is happening, too afraid that the worst possible news is coming their way. Once they've gone through their treatment for aplastic anemia, within a few months, when their blood counts start to get better and they're starting to feel better, each clinic, we're all waiting to give them that good news to see there, because many patients actually live a pretty healthy life once they get the accurate diagnosis and treatment for it. So we all come to our clinics every day to see that first rise in hemoglobin, that first rise in platelet count, and to be excited for our patients. We bind so closely with our patients and families through this process that feeling that you get by helping these patients out is what brings us to clinic each and every day. So I love taking care of patients with aplastic anemia. So I'm going to discuss more about what this means for you, how does it present, what to expect, mostly focusing on what questions to ask your doctors, because this is when many a times when you're diagnosed with this condition, this is the first time you're hearing it. So I hope the presentation gives you some questions if you have not already discussed with your doctor, to go ahead and think about some of these questions. Just some historical perspective. Aplastic anemia is a rare bone marrow disorder. It's diagnosed in 1 to 2 people, if you take about 1 million people. It's an immune condition. When you have it, because of the immune problem that you have, it prevents your bone marrow from producing new blood cells. Most commonly, patients present with low blood counts because of an inability to produce new blood cells. A pathologist in 1888 by name Paul Ulrich describes this case in literature of a young female that has present with high fevers, bleeding, and severe anemia. On examination of her bone marrow, he had found her bone marrow tissue to be empty. And described this condition by a Greek term, aplastic, which later came to be known as aplastic anemia. The picture depicted on the slide onto your right-hand side shows that if your bone marrow is normal, it has this healthy bluish pink tissue, which are your stem cells making your baby cells. When you have aplastic anemia, these cells are replaced by fat tissue. So the healthy cells are missing out in your bone marrow biopsy. Because the bone marrow looks acellular or hypocellular, it gives the name aplastic anemia. It has a biphasic age distribution. So this is not an adult or a pediatric disease. It can occur at any age, but there is like any other immune conditions, there are peak ages where it tends to happen. The one age group is between 10 to 25 years. And as we age in our 5th and 6th decade is this next second peak, as you see with most commonly with the other immune disorders such as Purette aplasia as well. The condition, when at presentation, how do you recognize you have a bone marrow problem or you have aplastic anemia? Patients, the 3 types of cells we all have are our red cells that help carry oxygen and gives us energy. And platelets are our tiny cells that help us in clotting, and white blood cells, which are our immune cells. So when you have low numbers of your reds, whites, and platelets, you might feel tired. Your family members might comment that you look pale. Because of lower hemoglobin, you feel short of breath. And because of low white blood cell, you might come down with frequent infections and fevers and rash subsequent to it. So your immune system is on the lower levels, and there is episodes of bleeding, be it menorrhagia or extreme menstrual cycles, epistaxis, bleeding through your nose. Things like that are the most common presentations when patients come down with aplastic anemia. The symptoms can be brewing for a bit of time. There is a variation. Some patients present more acutely, like the historical case I've described in the previous slide. Most of the time, there is a period of 3 to 4 months, people having had a viral syndrome and then presenting with like a gradual onset of symptoms. And they present either to an emergency room, or because they are so tired, or they have a bleeding episode, or they go to their primary care office and ultimately end up with the hematologist. So you can expect to be in an outpatient basis, or you can be worked up for this condition because if you have really low blood counts that require transfusions, you might be in the hospital while getting this diagnosis. Early on in the disease process, you may need transfusions because it is important for that to happen to make you feel better. So anemia gets better, and to prevent complications that come from this anemia impacting your heart or other organs in your body. So expect a few transfusions early on in the process while you're undergoing workup. You might get some other medications depending on your presentation. If you are having bleeding going on, you can get medicines that help your blood get thicker. And if you're getting an infection, you can expect to be on antibiotics. So there can be other medicines that are managing the complications of aplastic anemia. The way to get to the diagnosis is to do a series of tests. Typically, this is blood work and a bone marrow biopsy. Bone marrow biopsy is a procedure that is stigmatized as a painful procedure. While most patients tolerate this well, it can be done under local sedation or under conscious sedation. For children, we most preferentially do it under conscious sedation. While you're going through this procedure, it's a sterile procedure. You're either laying on your belly, as in the second picture, or laying on your side. And with the large bore needle called the Jamshidi needle, we go into the deeper tissues of your bone called the bone marrow and take some of the tissue out for studying under microscope and sending out tests. It's most important to pay attention that your team taking care of you are looking at all different possibilities before they arrive at a diagnosis of aplastic anemia. So let's review what causes low blood counts. There's a whole textbook of reasons I tell my patients before they get diagnosed with aplastic anemia as to what is causing their low blood counts. It is most important to make sure that there is no other signs of blood cancer, such as leukemia. There are no other infections that are causing you to have depressed blood counts, such as sometimes parvovirus, EBV, CMV, these are all the viruses your doctor should be checking for to make sure that before you come down with diagnosis of aplastic anemia, all these tests are done. Autoimmune conditions such as lupus, medications that can sometimes suppress your blood counts. So detailed history and physical has to be done along hand in hand with examination of your blood and bone marrow. What do we do with all the blood tests? Many patients come to me for evaluation of anemia and I take another 10 tubes out of it. This sometimes feels very contradictory to the patient because they come in because they're really worried about low blood counts and I'm taking more tubes out of blood. So I try and educate in their first session. It is going to take me X number of blood tests to get to your diagnosis, especially when we are dealing with rare diseases and a whole different possibilities. So what are we looking at when we do a bone marrow biopsy? When we take blood smear or blood sample and bone marrow biopsy, the first thing we do is examine the cells under microscope, what is called a morphological examination. This is how we rule out other blood cancers, if there is anything else going on in your blood work. We also do specialized testing on the samples that are obtained, such as changes in your DNA. These tests are called in situ hybridization, cytogenetics, or DNA sequencing. Some of these tests because they're specialized tests, you meet with the doctors, you go through lab work, and if you're in an outpatient setting, they bring you back a couple weeks later. Or if you're admitted in hospital, you're patiently waiting for your results to come back because some of these tests do take up to a few weeks, close to a month for some of these tests to come back. So I wanted to, if you're going through more recently, it's not unusual that it takes up to a month to diagnose this condition at times, because it is absolutely important to make sure we do not misdiagnose you. So because aplastic anemia is not a diagnosis that we send a test and it comes back positive and therefore you get the diagnosis of aplastic anemia. Like I mentioned before, there are whole other reasons that we rule out before we end up with the diagnostic test. So to give that time to your treating physicians is absolutely the right thing, and to partner with them and they get to know you through that process and provide you the supportive care that is needed within the first month, such as transfusions, antibiotics, or whatever is needed. At the same time, when I'm the treating physician, I'm constantly in conversation with it that month. As the lab tests are coming back, I speak to my team, my physician assistants, my nurses, what is going on with the patient as we come up with the diagnosis, especially the conversation with the pathologist. If you go back and read your bone marrow biopsy results, your bone marrow biopsy results never says the patient has aplastic anemia. The bone marrow biopsy always reads as, we do not see any abnormal cells. There are a decreased number of cells. Now, your clinician takes that information, puts the DNA testing together and all the other information he has, unlike this looks like a duck, quacks like a duck, this is a duck. So that's kind of the equation we come into. So you have a hypocellular bone marrow biopsy. All your genetic tests are coming back normal. There is no family history of it. I see such and such test positive. Therefore, I think we have a diagnosis of aplastic anemia. To come to this conclusion, I wanted to educate the community. There is a lot of conversation that is happening in the background among all the team members that are taking care of you to arrive at such a diagnosis. Because aplastic anemia is we express it in terms of a diagnostic challenge. Why do we take that time? It's absolutely essential to make sure we are not labeling somebody who has myelodysplastic syndrome, which is a blood cancer, as opposed to aplastic anemia, which is an immune-mediated cause. Sometimes myelodysplastic syndrome can have low number of cells in your bone marrow, and for all purposes, the bone marrow looks like the same as what I showed you in the very first slide, an empty bone marrow. But some of the molecular tests or some of the cytogenetics, the DNA changes test comes back, helping us diagnosing hyperplastic anemia, MDS in some cases, as opposed to aplastic anemia. At the same time, aplastic anemia co-occurs with many other things. Sometimes Fanconi anemia patients can present delayed in their lifetime, in their second decade, and can present with the hyperplastic MDS. So Fanconi anemia is a frequent differential diagnosis. Hyperplastic anemia is a frequent differential diagnosis. There are rare cases of other leukemias such as TLGL that can present similar to aplastic anemia. So So it takes time to do the accurate test and to establish the right diagnosis. This is the first step that we all need to arrive to confirm the diagnosis and sit down with the patient and their family member to go over your diagnosis and to rule out other different possibilities. So again, to conclude, diagnosing aplastic anemia, we look at your blood counts. Most of the times there are all the three cells are on the lower end. And at times, there are only two cell lineages that are lower. So two or three cell lines can be on the lower side. Your bone marrow should look hypocellular. And we may sometimes diagnose you at the same time with other blood disorders such as PNH, paroxysmal nocturnal hemoglobinuria. We look at the chromosomes by the cytogenetic test. We make sure the cells are not abnormal, meaning not dysplastic looking. And we look at mutations from the DNA sequencing to look at PIG-A and B-core are the frequently mutated genes in aplastic anemia compared to hypoplastic MDS. A combination of all these tests put together makes us arrive at the diagnosis of aplastic anemia. Yeah, you're meeting your doctor. They've given you the diagnosis of aplastic anemia. If I were the patient, having the knowledge of I have, what would I ask my doctor? Okay. Are there different kinds of aplastic anemia? If yes, what kind of aplastic anemia do I have? Is my family at risk of having this condition? My parents, my siblings, my children? Do I need treatment for this condition? If I do need this condition, I have a very important event coming up in my life. How long can we wait to be treated? I think these are some of the important questions you can ask your doctor, or your doctor might be having a conversation that is taking through some of these questions. If I do require treatment and I go ahead with it, when will I feel better? How long does it take for my treatment to work? And what are the chances that it is going to work? What if I get pregnant? What are the complications of having this condition that I need to be aware of? How about food, diet, sports, exercise, all these daily life activities? What do I do about them? And what does survivorship look like for this? Survivorship is a big thing for cancer survivors, but it is not the most talked about topic in aplastic anemia. So I want to touch in the next few slides on all of these questions and spend some time going over the most likely answers you'll be hearing from your physicians when you're talking about your treatment plan. So types of aplastic anemia. There is severities of aplastic anemia depending on how your blood counts look, how many cells are in your bone marrow, what we refer as bone marrow cellularity. You can be grouped into one of the three severity groups. They're called the very severe, severe, and moderate aplastic anemia patients. Moderate aplastic anemia patients, 50% of them have low blood counts, but are frequently transfusion independent. Whereas very severe and severe aplastic anemia typically end up in the inpatient, either malignant heme floor or bone marrow failure floor, because they need frequent transfusions. So these are the three degrees of severity that a patient can have. But based on the cause, they can be put in two different baskets. Those families or patients that have a genetic cause that they're born with called inherited bone marrow failures. And there are a whole book of conditions such as Fanconi anemia, SBDS, or DBA that genetic mutations in certain genes can cause this condition that can look like aplastic anemia. That's one basket. So genetic causes lead them to have less number of cells in their bone marrow, whereas an acquired bone marrow failure, acquired aplastic anemia is an immune cause. In a big percentage of these patients, you do not find the cause. You call them primary or idiopathic acquired aplastic anemia. And in some percentage of patients, a small percentage of patients, you do come across something that triggered their immune system. This frequently could be somebody who received a transfusion and developed a rare complication from it called GVHD, pregnancy, drugs, especially sulfur drugs and some of the antibiotics, viral conditions. As you see in the pie charts here, frequently in adult population, you have patients have acquired aplastic anemia, meaning it is not secondary to something you were born with. You picked it up along the way in your lifetime. And in others, we suspect you have an inherited cause, but the inherited cause is not known frequently in adults. If you take pediatric population, acquired aplastic anemia still continues to be a frequent cause, but there are many more patients in their first decade of life that are born with these inherited conditions, and the percentage of patients that are diagnosed with inherited aplastic anemia is higher compared to adult patients. So these are the different kinds of aplastic anemia you have. So this is the first question you'll be discussing: is this acquired or inherited? So that leads to, when your doctor is talking to this, you're asking the question, is my family at risk? You're going to learn more about this in Dr. Vladarsky's talk later in the next session. And he will talk to you about what are the patterns of inheritance. How do these diseases move from one member of the family to the other? This only applies to patients who have been detected to find a germline cause or something they're born with. Whereas in acquired, it's mostly a random thing that they pick on, and families are not at higher risk. So if you have acquired aplastic anemia, you're not at higher risk. Your sibling, your child are not at higher risk of developing these conditions. I know you'll learn more about Dr. Vladarsky's talk about how the inheritance works, but I've mentioned for the most common inherited condition, which is Fanconi anemia. It is an autosomal recessive condition. So that means it skips generations. That means your parents did not necessarily have the disease. They might just be carriers for it. And I've listed on the slide here some of the most common conditions and how the pattern of inheritance happens to this. And I'm excited you all will be learning more about it later in today's conference. Do I need treatment? So every case is unique. There are a subset of patients where we do surveillance and don't always have to treat. So this depends on the severity of your cytopenias. So not always, it doesn't apply to every single patient. Most patients that fall into severe and very severe aplastic anemia category will require treatment. And we will talk about how that looks like. But there are a group of patients, especially if you're diagnosed with small clones of PNH or a moderate aplastic anemia, your blood counts can be monitored safely if you're not requiring transfusions, if you're not getting frequent infections. This is called expectant management or observation. We make sure that the numbers are staying or getting better in certain cases by themselves. But it is important to continue to follow with the hematologist, even though you don't require treatment, because this disease course might change over time. But majority of patients do require therapy. So let's review the treatment options for that. So you got diagnosed, and how long can you wait? I've already mentioned to you, it takes about a month for treatment, a diagnosis to happen. We know that if you go beyond 1 to 2 months and there is more immune damage to your stem cells, your immune system is constantly impacting, there is going to be more stem cell damage. So it is important that although it takes a month to get to the accurate diagnosis, to not delay treatment beyond 2 to 3 months is extremely important, because many a times we are testing your siblings and family members as donors. So while transplant is being considered, it is on an average reasonable to wait along for a few months if transplant is being entertained as an option. But if immunosuppressive therapy is being considered for you, it is a wise idea to get treated sooner than later to decrease the amount of damage that is going on in your bone marrow and to rescue that healthy stem cells that remain in your bone marrow. It is known that delay in treatment has been shown in a few studies to lead suboptimal responses from available treatments. So this is an important point. I wanted to emphasize that make sure you get to the right group that needs to treat you, and make sure that the treatment happens within a reasonable time frame and not to prolong it too long. Okay. When you do require treatment, it is a combination of therapies. I'm going to walk you through what the names of these treatments are and how they are combined. The strategy, because it is an autoimmune condition, is to give you immunosuppressive therapy. They come as pills and they come as IV therapy. The biggest backbone right now is by an IV treatment called anti-thymocyte globulin, because it requires It's frequently associated with severe infusion reactions. You will be in a hospital while you get therapy. You'll get a big more needle into your arm or your chest, what is called the central line. It is required for administration of this treatment. You can, while you're going through this treatment, you feel like you have a flu-like illness. You have fevers, chills, rigors, because this product is obtained most frequently from a horse serum, rarely from a rabbit serum. If you're an international person attending online in US, we frequently use horse serum, but it is not unusual at times. They use rabbit serum to make this product because of the foreign proteins in these animals and your body reacting to that. You might expect infusion reactions, and the nurses that are taking care of you while you're going through this treatment, they know what infusion reactions to expect and give you appropriate treatments to help succumb some of this side effects that are happening. Weeks following this treatment, you experience a side effect called serum sickness, which is again like a low-grade flu-like symptoms. You might notice rash, joint swelling. You're given steroids to decrease the chance of serum sickness happening. So even after the IV treatment is done, because the medicine is still in your body, prednisone or corticosteroids are frequently given to decrease the chance of this side effect from happening. Immunosuppressive medications are frequently combined with this IV medication, and the most common names you might hear from your doctor are medicines like cyclosporin, which comes as Gengraf or Neosporal. There are different formulations to it. Tacrolimus or sirolimus. These are all combined together called mTOR inhibitors. They belong to the same category. Depending on your renal function and how you're tolerating a medication, these are pretty big tablets. So I hear from my patients frequently how they hate taking the medicine, but it is a life-saving medicine for patients with aplastic anemia. And I've left a visual of one of the formulations of cyclosporin that you might be taking. The third most common drug that is used in treating patients, children and adults with aplastic anemia is a medicine by name Promacta. The generic name is Eltrombopag. You will know this medicine because your pharmacist sits with you ahead of time and tell you that you're not able to eat 2 hours before and 2 hours after because there's food interactions for this medication. It comes in different formulations and the color changes with it. So your patients frequently remember, no, I'm taking the blue pill or the orange pill. And that kind of tells me how many milligrams they are taking. So most people tend to take this late in the night after the dinner or early in the morning and have a late breakfast because of the fasting requirements. As you take this pill, some of the things that your team is keeping an eye on is how are your liver number looking, because there is a certain liver toxicity with it and other side effects that can potentially be associated with it. There is a medicine by name alemtuzumab that is not infrequently used in upfront setting, but most commonly used in relapse setting. It is also an IV medication, but is frequently given subcutaneously into your skin. So it is not available as pill. It is another immunosuppressive agent similar to cyclosporin and similar to ATG treatment that we have talked about. What are the general concepts? So what are the doctors going through as they help you give you a treatment plan, depending on your age? Usually kids less than 18 and young adults that are less than 40 years, we triage the condition in a similar way. Do they have a matched sibling? Is there a good donor available? Matched unrelated donors are frequently being looked at and clinical trial purposes. Here at St. Jude, there is a clinical trial to look at patients that are unrelated, if that is a reasonable upfront therapy. But as a standard of care, if you have a reasonable donor, whether on trial or outside of a trial, transplant, if there is a donor available, that is the preferred choice in most patients. If there is no donor available or an immediately available donor, immunosuppressive therapy with antithymocyte globulin, with or without combination of Eltrombopag is given as part of your initial therapy. So you're admitted to the hospital, you're given a central line, you're in the hospital for monitoring for 5 days, and all the medicines are given to you. After that, you get discharged from the hospital on corticosteroids and other oral medicines that we have reviewed. And they wait up to 3 months with ongoing blood count monitoring and supportive to see any signs of early relapse. So you can ask your treating team on week 5, week 7, week 8, is the treatment working? What is going on? But you will not most likely hear an answer because it takes this medicine. I frequently give the example of a broken bone. A broken bone is less complicated structure than a bone marrow. And a broken bone takes 3 to 6 months for you to completely heal back with the help of physical therapy and stuff. Bone marrow is a much more intricate organ with that. So any change of medicines you do, any treatment you do, the longest you can wait is up till 6 months. I've seen some rare subset of patients take up till a year or two, but 6 months is that time point. In children, we look at it at a little bit earlier time point with the addition of L-Trombopac. 3 to 6 months is when you will really start seeing that movement in your blood count. So the first 3 months could be a little bit frustrating and requires a lot of patience on your end and on the treatment. And as we take you to supportive group, majority of patients respond to, fortunately, majority of patients respond to the treatment. So there is hope while you're going through this treatment. You will learn a lot more about transplant donors. What does that look like later in Dr. Sharma and Dr. Gurha's talk this afternoon as to how that looks like. Today, I'm going to focus for my talk purely on immunosuppressive therapies and what the outcomes are, what are the long-term outcomes. If you're responding to this combination treatment and you remain in a remission, slowly your treatment team will start tapering most of your medications, beginning with L-Trombopac will be the first medication to come off. The next one will be cyclosporin. There will be a slow taper over 3 to 6 months after your blood counts have normalized. Typically, the tapering process happens 12 months into treatment. If you unfortunately fall into that category that has not responded to the initial therapy, again, age comes into a factor. If you're a younger age person, we definitely, in case of non-response to upfront immunosuppressive therapy, we do a much more extensive search, reach out to that not responding donor to donate bone marrow for you to undergo bone marrow transplant. So bone marrow transplant is heavily entertained in that population. In adults older than 40 years, there is a good chance of rescuing 1/3 of the patients that have not responded to the initial therapy by a second round of immunosuppressive therapy with ATG. The ATG this time can be altered from horse to rapid, but if you had at least some response to horse, the same horse ATG therapy can be given the second time as well. So if you do not respond to 2 rounds of therapy, there are alternative immunosuppressive agents such as alemtuzumab that I've discussed. Clinical trials are heavily entertained, but most of the time we are looking at transplant as an option here. There are other agents such as anabolic steroids that could help in this condition. And I've definitely rescued some of those patients who have seen 2 rounds of therapy just with anabolic steroids. So although it is not a heavily entertained option, there's still hope for patients who have not responded to 2 rounds of therapy. Although that story remains rare, there is still agents that can work in that zone as well. Factors that influence as to how are the treatment teams or physicians that are treating you, how are we choosing transplant versus immunosuppression? Historically, it has been age of the patient because transplant comes with complications such as graft versus host disease, and this can be a tough complication to see through, and the mortality is higher as you enter into your 6th, 7th, and 8th decade. So depending on your age, your comorbidities, and the mortality from immunosuppression is relatively low to almost rare. So depending on your age, that is a big factor. Donor availability and the type of donor. If we have a half-matched donor versus a full donor, related versus an unrelated donor, what are the risks and benefits of each of the donor that we are looking at? What are the chance of engraftment, the donor cells coming into your body and being able to produce? All these risk ratios are calculated for each patient before we present whether transplant or immunosuppression would be the right choice for you. And duration since diagnosis, not infrequently we come across those patients who did not end up with the right doctor, and it's already been about a year or 6 months from when they had the first low blood transfusion. With long periods of being untreated, there is an increased phenomena of stem cell exhaustion. Most of your healthy cells have been attacked by the bone marrow. So there's too few cells to be rescued by immunosuppression. In that scenario, we do entertain transplant as an upfront, irrespective of the age of the patients. Sometimes patients look for all purposes like aplastic anemia, but have a significant hemolytic anemia from PNH, or they have a clonal marker or a DNA change that worries us. Depending on all these combination of factors, your treatment team will come up as, I think immunosuppression makes the most sense for you, and they'll have this conversation why they made that decision. For adults, the standard since 2017 has changed from ATG cyclosporin alone to include L-thrombopag in most patients because increased overall responses have been documented. But the addition of L-thrombopag has not decreased the number of relapses that patients experience after the first line of therapy. So the number of patients that are able to respond has increased, but there is still a chance of relapse, like in any other immune condition after upfront therapy. In children, depending on the institution that you are being treated, L-thrombopag, there is preliminary data of increased overall response rates for children as well. So L-thrombopag may or may not be added depending on your disease type. Again, if there are clonal markers that worry us, we try to stay away from them. But the standard has recently changed to include L-thrombopag in most institutions, even for children suffering with aplastic anemia, along with ATG and cyclosporin. Like I've mentioned, as you start to respond over time, most of these medications are tapered, and there will be a time where you would not have to take most of these medications. About 20 to 30% of the patients fall into this category called relapsed or refractory aplastic anemia. These are the patients that may have responded to aplastic anemia and a year passed by and they have low blood counts again. Or these are patients who never really responded to ATG to begin with. About 1/3, 20 to 30% of the patients fall into this category. And in those patients, it is critical to establish why did they not respond to the treatment. Is the diagnosis correct? Did they progress to one other disease? Because aplastic anemia can change to MDS and other blood cancers. Are those some of those people that have waited too long and there is a stem cell exhaustion, there are no stem cells to rescue? Depending on these causes, we can apply the next set of treatments. If somebody has responded to immunosuppression or had any sort of improvement in transfusion, we can consider another round of immunosuppression. Anabolic steroids, like if there is stem cell exhaustion, anabolic steroids or stimulatory agents such as romiplastim can be entertained in those patients that are not transplant eligible. The most common pathway that we take is whoever has a transplantable donor, we go ahead and give them unrelated donor or a haploid identical transplant. There has been increased activity in the most recent AAMDS scientific meeting of activity of romiplastim at higher doses, especially patients within the Asian heritage, that patients are more sensitive to romiplastim as compared to L-thrombopag with relapsed refractory aplastic anemia. Clinical trials, there are clinical trials through AMDS Foundation at different institutions available, such as Regeneron product 7257. So clinical trials are heavily entertained for those patients that do not have transplant as an option for them. When can I get back to routine? I think most people in the audience are probably thinking of this. This really depends on your response, but there is hope for being able to get back to a routine. On an average, like I mentioned, like a broken bone, it takes 3 months and up to 6 months for a full response to happen. So response are of a few different kinds. Your blood counts can completely normalize, or you can have improvement in your blood counts enough that you're not needing transfusion. When any of these events happen, you start to feel better. There are fewer requirements to continuous follow-up with your team. So on an average, I would say it takes 6 months of seeing doctors frequently, and your number of visits most of the time we expect to decrease and to get back to a routine thereafter. Remember, the distribution of any normal thing is a bell-shaped curve, so your story can fall in any extreme. You can be that person that can respond within 6 weeks, or you can be that person that is waiting patiently 6 to 12 months for a response to happen. I hope the fortunate part about treating aplastic anemia is most of these patients fall between those two standard deviations, and there is a great success in treating this condition with immunosuppressive therapy. What if I get pregnant? This makes most of the treating adult physicians a little bit nervous. People who have had aplastic anemia, there's a chance of aplastic anemia relapsing during your pregnancy. Or there are certain patients who get diagnosed with aplastic anemia while they're pregnant. The mainstay of treatment, depending on which part of pregnancy they are in, is frequently supportive care. So transfuse supporting platelets and red blood cells is a mainstay of treatment, and safely delivering the baby and having a healthy mom is the ideal target. So you might require more transfusions during your pregnancy. Pregnancy on a normal physiology is associated with anemia. So you have to work with the high-risk OB and a hematologist to be able to differentiate. Are you experiencing just pregnancy-related anemia that's related to iron deficiency or the volume that you're carrying, or is it really a relapse of aplastic anemia? So frequent follow-ups with both of these doctors will lead to successful pregnancy outcomes, but one has to work closely with an experienced hematologist that has helped other people carry on successful pregnancies with the aplastic anemia. There have been rare case reports of immunosuppressive therapy and stimulatory agents being employed successfully without any birth defects, but this would be done in a case-by-case basis only when they're experiencing extremely severe low blood counts. Diet, exercise, sports. So common knowledge is what I talk to people. We encourage exercising. Ongoing fatigue is a major issue to exercise. So you might want to avoid those activities that are causing chest pain. So extreme exertion is not recommended, but keeping aerobic activities, walking, jogging, small things are encouraged during your treatments while going through aplastic anemia. Preventing infection is a major focus of my conversations with my patients, to making sure you get all the vaccinations that are required yearly, the flu vaccine, any other preventive vaccines. Avoiding large crowds would be a good strategy in the initial part of your treatments. Most relatives and friends want to make sure that we are doing okay. In the initial part of your treatment where you're immunosuppressed, I would advise my families, if they have sick relatives, to postpone their appointments, at least in the initial period of their treatment, especially during cold and flu seasons. Washing your hand frequently is the most common strategy to cut down the spread of any germs. Regular dental care will decrease the amount of gum or tooth infections that that many of my patients suffer from. Healthy balanced diet is the key. Food hygiene is extremely important. If you're eating cooked vegetables and all peelable fruits are ideal. I would mostly say avoiding raw meat and fresh salads that we do not know how they are prepped from outside are the food things that I would tend to avoid. Mostly homemade meals are preferred, or cooked meals are preferred for my patients. Pay attention to your inner self. Emotional health and positive thoughts are extremely important as you go through this long process. So all of these lifestyle changes are extremely important, along with your medical therapy that your treatment team will be. Thankfully, at St. Jude, we have amazing social work and case managers at helping out. Hopefully, we start to pick more that up in adult world as well. Transition. So what happens to that kids? Because medicine is divided into two subsets of pediatrics and adults. There are a whole group of patients that fall into this adolescent young adults that are overlooked by the way medicine is practiced in our systems. There are many patients that are born with genetic defects that give rise to bone marrow failure or malignancies later in life. I've mentioned some of the genes that frequently are recently discovered, and when aplastic anemia or MDS can happen, it's frequently that they're diagnosed as a child with having an anchor D2 mutation or having low platelet count from RUNX1 mutation. And as they age, they're done with their pediatric hematologist and go back to their primary care office and are kind of lost in the system, not being established with the hematologist. And there is risk of when you lose that care, early diagnosis of any of the complications that can arise out of this condition. will be missed. That window of catching complication from your disease will be missed. So here in Tennessee, pediatric and adult teams have combined to develop a transition care that does not overlook patients that have bone marrow failure conditions such as aplastic anemia, because it is being known that early diagnosis of any conditions that can arise of having aplastic anemia are better diagnosed early. And so surveillance is a key strategy. And again, surveillance is another thing that is frequently overlooked, especially as people move on to their second and third decades of productive life and are caring for their progeny. It is extremely important that you go back to your condition and make sure you have a trustable team that you continue to follow, so you avoid any delays in diagnosis if you unfortunately end up with any of the clonal disorders such as MDS or other malignancies that tend to happen as a late occurrence. Surveillance, patients and families living with these conditions who are in remission should be aware that there are long-term risks from having aplastic anemia, and there is an extreme significance for the need for surveillance. Things like PNH, MDS, leukemias, although the risk is low, that you are at higher risk compared to the rest of the population just from having the diagnosis of aplastic anemia. And these can manifest later in the decade, in your fifth decade, in your sixth decade. So to establish that relationship is extremely important. Surveillance leads to early diagnosis. Early diagnosis avoids unnecessary chemotherapy and broadens your treatment options. Better outcomes are always there with a continued surveillance. I really wanted to emphasize that. In summary, aplastic anemia is a very treatable blood condition with a good long-term outcomes. Surveillance is key to early recognition of long-term complication. And it's early in your diagnosis, get to the right team. Please avoid any delays if you're able to, so that you can get to the right treatment when indicated. I appreciate all your time. And I thank the partnership of all the hospitals in Tennessee, in Memphis, coming together, Regional One Baptist and St. Jude Children's Hospital, and partnering with Aplastic Anemia for being able to interact with you directly today. Thank you so much. I appreciate the opportunity.
Thank you so much, Dr. Thota, for the wonderful presentation. We do have some questions, so we'll go in between questions from the audience to online. We'll start in-house. Does anyone have a question in-house for Dr. Thota? Okay, so one of our first questions online is there a difference between taking liquid cyclosporine or using a pill, and why?
So I think there are subtle pharmacokinetic differences in absorption rates for cyclosporine, but the best way to answer this is actually to measure your serum levels. So most of the time, unless it's a child, we frequently prescribe pills for most of my adult patients. If somebody has issues swallowing and have a PEG tube, rarely did I go ahead and prescribe the liquid formulations. There is certain pharmacokinetic differences, but the way your treatment team can identify this is by measuring the levels. So you can really go with how your kidneys are doing and how the cyclosporine levels are doing. So I think pharmacist is one person I have not mentioned in this talk. So there are subtle variations. So if you're taking, for example, 150 milligrams of cyclosporine 2 times a day, and if you had to switch to liquid formulation, you will see that your blood levels for cyclosporine have altered after you've changed. It's not always true, 100% true. Some people do maintain the same levels, but there's an individual variation to it. So I think cyclosporine levels are the most important thing to focus on, irrespective of the formulations that you're taking.
Thank you. Our next question online is multiple blood transfusions cause ferritin toxicity. At what point do you treat this condition?
That's a great point. People who have received the new guidelines say if you have received over 12 to 20 transfusions throughout your treatment time, that is an indication for starting treatment, phlebotomy. So when your blood counts have normalized, if they have normalized, phlebotomies are one of the strategies we establish to treat iron overload. But ferritin values are the other ones. Hopefully, we do not get to that stage where liver dysfunction or organ toxicity has happened because of high iron overload. Different ferritin values. So the initial trigger usually is numbers like 500 and over, but most of the times we try and keep ferritin below 100. So sometimes this is achieved using not just phlebotomies. If you're a little bit anemic, you have improved your blood counts, but you're not quite there to donate or phlebotomize you. We frequently use medications such as desferoxamine, Jadenu. Some of them are sub-Q pumps, some of them are pills to decrease iron burden. That's an important part of surveillance too, and it is a key step right after you're done with your treatments to discuss with your doctors. Thank you for bringing that up.
Thank you. Any questions from the audience live here? Okay, we'll go to another question online. Weekly blood is taken to adjust the cyclosporine level and test the creatine level, and dosing is adjusted. Is there any research to determine the optimal level of cyclosporine and manage that level with side effects of cyclosporine?
So the question is, what is an optimal level of cyclosporin?
And is there research to determine the optimal level of cyclosporine?
So 2 to 400 is the most common. So there are different levels. Cyclosporin is 200 to 400, what we try to maintain. Between that range, any number variations do not really matter. That is a therapeutic range we aim for. Sometimes when you see people are on the high normal end, like in the 400s, they start to experience creatinine difference. But if somebody is at 200, say, for example, that's still a reasonable, as long as they remain in that range, the absolute number doesn't matter. That's the range that we aim for. So there is no research for 300 is better than 400. We know that between 2 to 400 is actually a pretty reasonable range to stay in. These values are different for sirolimus and tacrolimus. So I hope that answered the question.
And how do you manage the side effects of cyclosporine?
That's actually one of the important, some of the times I've seen patients for second opinion. The toxic children actually tolerate cyclosporin reasonably well compared to those in their third, fourth decade. The most frequent complaints that I hear are tremors, muscle cramps, headaches, and objectively what I see is renal dysfunction, electrolyte abnormalities, things like that. Magnesium is actually a really good friend. I always prescribe my cyclosporin along with magnesium oxide or sulfate. You have to know if you take too much magnesium, you'll have diarrhea. But magnesium is one of those things that decreases tremors, headaches get better. If you do prescribe with cyclosporin without magnesium, people can experience this, what can be labeled as intolerant, and people tend to quickly move on to other immunosuppressive drugs to try. It's a class effect, but cyclosporin especially has to be given. If people do end up with high blood pressure and things like that, you have to use your general internal medicine knowledge of giving antihypertensives. If the side effect is so bad, interruption for treatment is the right way to choose. So if somebody has ended up with severely deteriorated kidney function, you have to stop your cyclosporin treatment, get hydration, give your kidney some time to recover, and resume doses at a lower level and slowly titrate up. Within the first 6 months, it is ideal to keep your cyclosporin values within therapeutic range. As you start to taper, once the counts have normalized, the value of cyclosporin doesn't really matter.
Thank you. Any questions in the room? Sure, Ron, go ahead.
Are there any long-term neurological effects of taking cyclosporine?
I have the most frequent thing that we see is actually dermatologic. Skin cancers is the most thing because of immunosuppressed state. So avoiding sun and things. In terms of neurotoxicity, especially in 5th and 6th decade of life, people who frequently have like pre-diabetes and other predisposing factors, I've seen like grade 1 to neuropathy. So like burning in their feet, and sensations like that. It doesn't happen to everyone, but there are certain people who are predisposed to, especially if they have other risk factors. So neuropathy is definitely something I've noticed in people. Tremors are reversible. So tremors happen while you're taking, and most people can tell their values because, they see that the tremors are worsening and like, I think I'm getting too high on my cyclosporin, but tremors are usually a reversible thing, and magnesium helps with that as well.
Thank you. Our next question from online comes from a patient who is 63 and is in remission from severe aplastic anemia. They'd like to know, when should you consider a transplant before having a relapse? They don't want to get any older and less able to deal with a transplant before a relapse.
Yeah, that's a great question. I appreciate it. So transplant age, even when I was in training 10 years ago, I've never seen on a transplant for that was in the 7th decade. The supportive care has improved. So transplant is no more an age dependent variable. So continue to exercise and stay fit. So it remains an option for you, but what is the indication really? So I think surveillance is the point that I would like to go back to at this point, like once a year at times, depending on how far out from treatment you are. Blood counts are always monitored every 6 months at least. But early diagnosis can be of any clonal complications or relapses are recognized by bone marrow biopsies too. So as part of surveillance strategy, every so often we have the patients go through bone marrow biopsies. So without a relapse, without any clonal markers of concern, there is no indication for transplant for somebody in remission. But really early diagnosis, and then if it is supposed to happen, then that is the indication for transplant. Because 60% of the patients have the first episode, go into remission and stay out of it. Only 1/3 of the patients relapse. So the odds of your disease happening are in your favor, staying in remission are in your favor. So just continue surveillance and continue to exercise would be my advice.
Thank you. Our next question is, after 6-month treatment of ATG, white cells are normal, platelets have gone up, but hemoglobin hasn't really gone up at all. After 6 months, can you still expect to see a response? If not, what next?
Okay. Like I said, responses can be of everybody's story is different. For a lot of people, it's actually platelets that tend to be a little bit more stubborn. Hemoglobin not recovering, but platelets and white blood cell count recovering is rather a rare story. Just transfusion dependent, but white and platelet counts being normal. Usually that's a patient, there's still chance of hemoglobin recovering. Like I said, there are patients beyond 6 months that can take time for hemoglobin to get better. It is important to establish why they're anemic. Is it coming from aplastic anemia, or did the PNH take over? Is there a hemolytic process that is going on? That's the first step to recognize. Are there any viral things going on? Because you're on cyclosporin, you can acquire any viral illnesses. So look at other differential possibilities. Make sure your B12 is okay and other things. So look at every other possibility that it can be, that don't blame it automatically on aplastic anemia. If it is aplastic anemia, a tapering should not be entertained at least until 12 months. So give it some more time, wait it out till 12 months. If the condition continues, then, somebody, depending on the age, you really don't want somebody to be iron overloaded. Organ toxicity can happen from it. So then it brings a conversation. If truly the aplastic anemia were to relapse, you will see the other counts will come down. Or if the medications you're on are optimal, the hemoglobin should be getting up. So monitoring is what will happen for the next 6 months with looking at all the different possibilities. And depending on if the condition were to relapse, you'll see the other numbers will go down and other treatments are entertained at that point. Until then, continue the course, make sure cyclosporin levels are optimal until another month, because there's still a chance for recovery.
Great. Thank you so much. Any questions from the room? Okay, we'll go with our next one online. Is there a difference between magnesium oxide, sulfate, or chloride, or any of the other magnesiums?
There is a distaste with one of the formulations. I believe it's the sulfate. Most frequently used is magnesium oxide. They're all over the counter. It's really your tolerability. I personally have not heard from many patients about different formulations having different impact on them. The one thing I did want the community to know that your magnesium levels that your doctors measure don't really correlate to the functional magnesium. So your levels might be 2.4, 3, 4 normal, yet you might still have some tremor. You will never overdose on magnesium. The way you overdose on magnesium, you'll have increased GI motility. So up to 2 tablets can be taken. So a total of 400 milligrams can be taken daily. I don't think there's a difference in formulation, but my knowledge could be limited on that.
Thank you. Our next question comes from a patient who just completed ATG treatment 4 weeks ago and is currently on a prednisone taper. They are experiencing severe knee joint pain. They'd like to know, is this due to the cyclosporine, and how would one best treat this joint pain?
Okay. So if they're 4 to 6 weeks out, usually there are a couple differential diagnoses for that knee and joint pain. It could be a sign of serum sickness. Usually it doesn't tend to happen beyond 30 days. 30 days is the most frequent time. Up till 30 days is the most frequent time. So going up, if it is felt, even though it's at a delayed time point, if it is felt due to be that, prednisone is the treatment. Going up on the dose is what is going to be helpful. If you don't see it frequently with serum sickness, you actually see a swollen joint. If it is not a joint, but it's a muscle or a tendon that's causing that, it's usually like a cramp-like phenomena from cyclosporin. So adjusting the levels a little bit, if the way to diagnose it to say this is cyclosporin and not from serum sickness is to give a small break from cyclosporin. Typically, it takes 3 to 5 days for the levels to come down and people feel better. If it's really that, then maintaining on the lower end of normal, so 150 to 200 is probably what needs to happen. But again, hydration, magnesium, quinine water are the things to help out with that joint issue.
Thank you. Is there a difference between cyclosporine and tacrolimus? And what is that difference, and is one preferred over the other?
There are certain unusual complications some patients come across. For all purposes, therapeutically, both are similar in terms of response rates. Tacrolimus is felt to be a little bit better for people with renal disease. And the other thing is with cyclosporin, people rarely accumulate fluid because of it. If that is happening, people switch from cyclosporin for tacrolimus. The most common experience has been with cyclosporin. So most of the physicians are most commonly starting with cyclosporin only when they come across a toxicity that is attributed to cyclosporin that is not frequently seen, such as fluid retention, renal dysfunction. Do they frequently change over to tacrolimus? But for therapeutic purposes, they're both similar.
Thank you. This question comes from a patient, and I believe you addressed this earlier, but how restrictive does life need to be if you're in remission, but you're still taking cyclosporine? The patient knows to be concerned about infection, but they like to know about possibility of meeting with family, having workers in the house, and especially in light of COVID.
Thanks for asking that. That's also an important lifestyle question. It is usually the first 3 months that you're most immunosuppressed. If you're only cyclosporin, there are many, many patients that are on cyclosporin alone. So just you should be able to phase back into a routine life when you're on cyclosporin monotherapy. Typically, your team puts you on preventative antibiotics or antivirals. Most of the time it's acyclovir. Sometimes it is prevention with Bactrim and things like that. And we typically measure for how your lymphocyte count is doing, how your CD4 count is, and things like that. So once you're on appropriate preventative antibiotics, you should be able to carry on most of it's a duration from ATG treatment. I believe after 3 months, there is enough recovery. You're on appropriate preventative that you should be able to have a cleaner in the house. Just do the routine things that I have mentioned, especially with COVID, stay a bit far away, leave the room ventilated, wash your hands frequently, things like that. So common sense stuff.
Thank you. This question is, if aplastic anemia is not considered a cancer, how does an aplastic anemia patient then evolve to MDS, which is a cancer?
Yeah, that's a great question. There are many people at risk for leukemia or MDS, which are blood cancers. Aplastic anemia is not considered a cancer, but it is, for example, there's a new phenomena described as clonal hematopoiesis. These, as we age, we pick up clones that puts at for all purposes, because we don't run that test, an individual doesn't know that they're at risk of leukemia, but all of us carry an X percentage of leukemia. As a group, when we have taken aplastic anemia together and compared them to what we thought was general population, now even general population, is at higher risk of different kinds of cancer. It's known because there is a certain bone marrow damage that tends to happen, inflammation. It's long been linked, inflammation and cancer have long been linked. People with autoimmune conditions such as lupus, rheumatoid arthritis, ulcerative colitis have a higher incidence of MDS as well. It is the same inflammatory thing that certain cells that have defective ways of repairing their genes survive better in that autoimmune environment. I think that's what makes somebody who has had an immune condition predisposed to a blood cancer. It's the same phenomena similar to people with other immune conditions that I have described. It's just the close link between inflammation and cancer.
Great. Any additional questions from in the room? Well, thank you so much, Dr. Thota, for sharing your time and your expertise with all of us today. If you're online and you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing the session, clicking on replay, or by navigating the on-demand tab in the hub, on the platform hub. If you have any additional questions, please send them to us in 3 ways. Send an email to help@aamds.org. Call our helpline at 800-747-2820, or submit your question to our Facebook page. If you're watching online, please take a few minutes and complete the online survey. Your input is important to us and helps us manage our incoming educational programs. Also, be sure to visit our exhibit hall online, and you can chat with our conference sponsors. Our next session will begin at 10:30. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our session.